Positioning Lesson 8 is Hip and Pelvis, the final positioning lesson in this series. Hip and pelvis radiography carries unique clinical urgency because hip fractures are one of the most serious injuries in elderly patients, and a positioning error on a fractured hip can directly worsen the injury. 14 minutes. Pay close attention to the trauma precautions. AP pelvis. Patient supine, true AP. The mid-sagittal plane perpendicular to the table, bisecting the IR. Both ASIS equidistant from the table surface, no tilt. Arms alongside the body and outside the field. Feet, internally rotated 15 degrees. This is the standard for routine AP pelvis when hip fracture has not been confirmed. Internal rotation counteracts the natural anteversion of the femoral necks, their forward angle, bringing them parallel to the IR. Without internal rotation, the femoral necks appear foreshortened and the lesser trochanters are prominent. With internal rotation, the femoral necks are seen in their true length, and the lesser trochanters are brought medially into a barely visible profile position. KVP 70 to 80. Ishi 40 inches. Grid required. CR perpendicular to the table, centered at the level of the STS midline. Trauma precaution. Never internally rotate the feet if a hip fracture is suspected. Any rotation of a fractured femoral neck causes severe pain and can displace the fracture. Ask about clinical history before positioning every pelvis. If fracture is suspected, leave the feet in neutral, image as found, and notify the clinical team. Evaluation. Iliac wings symmetrical. Sacromidline. Femoral necks without foreshortening. Lesser trochanters barely visible on the medial femur. Obturator foramina open and symmetric. Both SID joints included. L5 visible. Pubic symphysis midline. AP hip. Same positioning as AP pelvis but coned to a single hip. Internal rotation 15 degrees if fracture is not suspected. CR. 1 inch medial to the ASTS and 2 inches inferior. Alternatively, centered midway between the ASTS and the pubic symphysis. Must include acetabulum, femoral head, neck, and proximal shaft. Greater and lesser trochanters both included. Lauenstein, frog leg lateral. Patient supine. The hip and knee of the affected side are both flexed 90 degrees, and the thigh is abducted 45 degrees. The limb goes into a frog leg position. CR. Perpendicular to the femoral neck at the level of the greater trochanter. This is the routine lateral hip for non-trauma cases. Best for leg cavernous disease, slip capital femoral epiphysis, and routine hip evaluation. Cannot be used if fracture is present or even suspected. Flexing and abducting a fractured hip is dangerous. Axiolateral, Danelius-Miller. The trauma lateral. Patient supine, do not move the injured leg. The opposite hip and knee are flexed maximally, knee to chest, moving that limb clear of the beam. The IR is placed against the lateral aspect of the injured hip, perpendicular to the femoral neck. CR, horizontal, mediolateral, through the groin, perpendicular to the IR. This gives a lateral view of the hip without any movement of the injured limb. This is the only acceptable lateral hip view when fracture is confirmed or suspected. For hip fracture and trauma concepts. Femoral neck fracture. The most common hip fracture. Most prevalent in elderly women with osteoporosis. Types by location. Subcapital. Most common at the base of the femoral head. Transcervical, mid-neck. And basis cervical at the base of the neck, just above the trochanters. The critical complication is avascular necrosis, AVN. The blood supply to the femoral head enters through the femoral neck from distally. A displaced neck fracture disrupts this supply. Classified by the Garden system, 1 through 4, based on displacement. Intertrochanteric fracture. The fracture line runs between the greater and lesser trochanters. Extracapsular. Lower AVN risk than femoral neck fractures because the blood supply is not disrupted. Typically comminuted in elderly patients. More blood loss than neck fractures. Axiolateral trauma protocol. Patient supine, do not move the injured leg. Opposite leg flexed out of the beam. IR against the lateral hip. Horizontal CR through the groin. This must be documented before any surgical planning. Required after reduction to confirm reduction. Acetabular fracture, Judet views. 2 obliques taken bilaterally. Iliac oblique. Patient 45 degrees toward the affected side. Demonstrates the posterior column and iliopectineal line. Obturator oblique. Patient 45 degrees away from the affected side. Demonstrates the anterior column and ilioischial line. CT is gold standard for full acetabular fracture characterization. 5 special pelvis views. Bilateral AP sacroiliac joints. Standard AP pelvis position. CR. Angled 30 to 35 degrees cephalically. This angle opens the SID joint spaces, which are naturally oblique to the frontal plane. Both joints demonstrated simultaneously. Ordered for sacroiliitis, ankylosing spondylitis, inflammatory arthritis. Posterior oblique. Patient rotated 25 to 30 degrees toward the affected side. CR. Perpendicular. Demonstrates one joint at a time in profile. Both sides imaged for comparison. Inlet pelvis. Patient supine. CR angled 40 to 60 degrees caudally toward the feet. Demonstrates the pelvic ring as a true ring. Shows AP and mediolateral displacement of fracture fragments. Used for pelvic ring fractures and sacral fractures. Outlet pelvis. CR angled 30 to 45 degrees cephalically toward the head. Demonstrates superior and inferior displacement of pelvic fragments. Sacral foramina visible. The inlet and outlet views are standard supplements to the AP pelvis in major trauma. Pédiatrique DDH évaluation. Developmental dysplasia of the hip. 3 lines assessed on the AP pelvis. Hilgen-Rayner's line. Horizontal through both triradiate cartilages. Perkins line. Vertical through the lateral acetabular edge. The femoral head ossification center should sit in the lower medial quadrant formed by these lines. Shinton's line. A smooth arc from the medial femoral neck to the inferior pubic ramus. Disruption indicates dislocation. The bar chart shows MES adjustments from standard AP pelvis technique. Large adult patient over 300 pounds. Increase MES by approximately 70%. Significantly more tissue to penetrate. Osteoporosis. Decrease MES by 20%. Reduced bone density attenuates the beam less than normal. Post-surgical with hardware. Increase MES and KVP for total hip arthroplasty. The metal prosthesis requires additional penetration. Increase KVP 5 to 10 and MES 15 to 20%. Pediatric under 5 years. Decrease MES to approximately 40% of adult standard. Very thin anatomy. Shielding considerations. Male patients. Testicular shield placed directly over the testes when the gonads are not in the field of interest. Female patients. The ovaries lying near the acetabula. Shielding must be done carefully to avoid obscuring the anatomy of interest. When in doubt on any pelvic exam, consult the radiologist before shielding. 3 hip and pelvis questions. The answer is B. Axiolateral, Danelius-Miller, horizontal beam, no movement of the injured leg. With a suspected hip fracture, the frog leg Lauenstein lateral is absolutely contraindicated. Flexing and abducting a fractured limb can cause severe displacement, vascular injury, and extreme pain. The axiolateral allows a lateral view of the hip without any movement of the injured side. Patient supine, opposite leg out of the way, IR against the lateral hip, horizontal CR through the groin. This is the only safe option. The answer is B. Places the femoral necks parallel to the IR, reducing foreshortening. The femoral necks have a natural anterior angulation, anteversion, of approximately 10 to 15 degrees. Without internal rotation, the necks are oblique to the IR and appear foreshortened on AP projection. Internally rotating the feet 15 degrees counteracts the anteversion, bringing the femoral necks parallel to the IR and displaying them in their true length. The lesser trochanters are brought to medial profile as a byproduct, but the primary purpose is accurate neck visualization. The answer is C. APSID joints with a 30 to 35 degree cephalic angle. This view uses the cephalic angle to open the sacroiliac joint spaces, which are naturally oblique and not visible on a standard AP pelvis. Both joints are demonstrated simultaneously on a single view. The inlet view uses a caudal angle. The outlet uses a cephalic angle, but for visualizing sacral foramina and vertical displacement, different purpose. Lesson 8 complete. You covered AP pelvis with the internal rotation technique and the critical trauma precaution, AP and lateral hip, Lauenstein frog leg for routine, Danelius-Miller axiolateral for trauma, hip fracture classification with garden staging and AVN risk, Judet acetabular views, sacroiliac joint projections, inlet and outlet pelvis, DDH evaluation, and technique adjustments for hardware and body habitus. That completes all 8 positioning lessons. Every view in these lessons appears somewhere on the ARRT Registry.